current U.S. educational initiatives in palliative care, and these are all within the last 5 years, palliative care in some fashion is now a required part of the postgraduate training for people in internal medicine, family practice, and neurology as primary specialties. In secondary specialties, medical oncology has palliative care as a special domain of requirement. That is, when the residencies get reviewed every few years for accreditation, they're asked, what are you teaching in this area? What I didn't include on here was that as of the year 2000, the licensing board for medical schools now requires end-of-life care training. So as of the year 2000, all medical schools in the United States are supposed to have some end-of-life training. The exact standards of what those training must compile has not been written yet. Other initiatives include a residency education project. We're coordinating work in internal medicine, family practice residencies across the country, helping them put in place an end-of-life curriculum. Because even though it was a requirement, they didn't have anybody who was teaching it previously. So there's a group of us working on from a grant project, working now with about 200 different residency programs, helping them to integrate an end-of-life curriculum as part of their normal curriculum. The EPERC project you'll hear about. There are 2 national faculty development projects, one at Stanford, one at Harvard, where they recruit faculty physicians and put them through an intensive training program in how to go back to their academic institutions and teach end-of-life care. And last is the National Board of Medical Examiners End-of-Life Project through a grant from the Robert Wood Johnson Foundation. The National Board, which is the certifying board for physicians in the United States, was asked and agreed to review all of their questions for the boards and rewrite and added new questions related to end-of-life care. So that provides a nice stick at the end from an educational perspective of helping to facilitate change. Just to review, these are the educational domains we're talking about within palliative care. These are familiar to this group. This is a slide I put up to just always impress me that people don't know what they don't know. This is from a course I teach for faculty physicians at my medical school. And at the end of the course, I do ask them to use what's called a retrospective pre-post test. Now that you've been through the course, tell me what you thought you knew at the beginning of the course. As opposed to, if you ask them the first day, they'll say they know all these topics. But at the end of the course, you can see that what they rated, the yellow is what they thought based on the end of the course, what they really knew at the beginning of the course. What the faculty thought was that in terms of particularly in areas of symptom control and hospice care, they didn't know anything. And so there's a huge gap between what people think they know and what they eventually go on to learn they don't know. Now, the question of needs assessment came up in the last session, and the needs assessment question I like to ask more than any other is when I'm with a group of physicians is, what's hard for you? Not what don't you know, because then physicians will sit on their hands. But what's hard for you? What's difficult? What is difficult for you in the care of patients with serious life-threatening illnesses? And these are the issues that commonly come up. Identification of the dying. How do I know who's dying? Which is, we know the cancer patient who's dying, but we often don't know other disease states. Application of ethics and communication skills, particularly surrounding DNR, artificial hydration and feeding, issues of futility, and family conflicts. Jose mentioned in the last session that that was the issue that comes up most frequently, and I have to second that. When I'm with a group of primary care physicians and I say, what's the hardest thing? The first thing they usually say is dealing with family and conflict, around conflicts. Usually, family wants me to do more or less than I think is appropriate. Issues of symptoms and pain management are secondary. Those always come in later in the discussion than primary. And if you look particularly around pain management, the issues that bother people are fears. They're attitudinal issues. It's not what's hard for me because I don't know the dose of morphine. It's hard because I'm afraid to use what might be a recommended dose of morphine. And educationally, dealing with fears and attitudes is much more difficult than dealing with facts. So it's really critical to look at issues of what is hard. Teaching methods for primary care physicians, really because you need to focus on where they're at. They must be learner-centered. They must include an opportunity to explore personal attitudes. They must be based on experiences of the learner. And they must be experiential. clinicians must have an opportunity to learn through role play, direct calculations or writing prescriptions, demonstrating symptom assessment, demonstrating treatment planning. Really crucial issues. They must be experiential. They must be mentored, and there can be a lot of self-study. Most physicians are pretty, bright people, and given the right materials and the right motivation, they can do a lot of self-study, particularly when it comes to factual knowledge. They can learn a lot of this on their own. Teaching materials, of course, can include all of these things. Learning objectives, course syllabus, content outlines. I put content outlines, lectures, AV material, and policies and guidelines all in the same line because they basically all represent provision of facts and in different modalities. Self-study material, discussion case studies, skill-based teaching material such as OSCE stations, and then a whole series of different learner assessment tools. Putting it all together, designing an educational program for physicians in practice. First and foremost, who's the audience and what do they want to learn? Now, you can know that before you walk in the room by asking yourself the question, what's hard for physicians? And if we had more time, we can go through this as an exercise. I'd have everybody write down the 3 things they think that physicians find hardest to do. And you would come up likely with that original list. The second thing is to match the learning objectives to methods. So if your objective is for people to know how to do a pain assessment, what you really want them to know is how to demonstrate a pain assessment, then your learning methods need to include some way for physicians to demonstrate that they understand how to do a pain assessment, typically through a role play or an OSCE station, rather than a lecture of these are the components of a pain assessment. Use overlapping methods and materials to reinforce content, and always, always include opportunities for attitudinal reflection. End-of-life care is fundamentally about feelings and emotions because clinicians develop feelings and emotions and attachments to their patients, and dying disrupts those. So issues of personal emotions and personal feelings always must be included in an educational session, whether it's about pain management or dyspnea or giving bad news. There must be some time put aside for physicians to allow an opportunity to self-reflect and think about the meaning of that. I was asked to provide what are some of the popular educational resources. These are the ones that are used in the United States that I see most commonly requested. The EPERC material you'll hear a lot more about. The American Academy of Hospice and Palliative Medicine has a core syllabus, which can be used as a teaching guide. It's sort of everything a hospice medical director should need to know. That's available through their website, which is aahpm.org. I have a whole series of teaching materials that are very popular and people want. I have brought some brochures. The Buckman communication modules, which are really kind of the state of the art for teaching communication skills. Unipacks, which are a series of self-study modules designed for practicing physicians, particularly those who want to pass the hospice boards in the United States. Again, through the Academy of Hospice and Palliative Medicine. They're very good content modules, self-study guides, they have problems. And fast facts and concepts. How many of you here have ever heard of fast facts and concepts? Nobody. Okay, I'll get to that in a minute. One final thing about education, and then I'm going to switch gears and talk about the EPERC project, is what is the goal of education? Is it to improve health professional education, or is it to improve clinical care and patient-family outcomes? I suspect it's more the latter than just to make people do better on a test. And if that's true, then I think educationally from your project in Pallium, you need to consider moving outside the education box. Because we know that wherever there's an educational domain where attitudes are a major part of the issue or problem, that education alone will not lead to improved care. We knew that we documented this with pain management for the last 20 years. And end of life is even more attitudinally based. So what really needs to do is to combine education with methods to institutionalize improved healthcare practices within individual healthcare facilities. Now you have a provincial basis for your healthcare, but healthcare fundamentally is administered in a facility or a region or a basis. And each one has its own culture, and therefore each one needs to be done a little bit differently. And institutionalizing palliative care really includes 5 components: commitment, There needs to be a commitment of administrators, somebody said that in the last session, to make change happen. There needs to be assessment, that is identifying pain, identifying who is dying, identifying seriously ill patients. A system of responsibility. What happens when care is bad? Who takes ownership? Who makes it better? Education for all health professionals, patients, families, and a series of standards. And clearly Canada is way ahead on the concept of standards development, but those need to be localized within individual facilities. This is one resource to help. This is in the US that's looking at improving palliative care services across the country. It's called CAPC, Center to Advance Palliative Care. They have a variety of educational and institutionally based resources you can access through their website, and they're going to have a palliative care manual that describes a lot about institutionalizing palliative care that will soon be available. Those are the websites. Okay, and lastly, I was asked to talk about EPERC, which is the End-of-Life Physician Education Resource Center. This was a project developed by myself and the head of education at my medical school at the request of a task force of the Robert Wood Johnson Foundation. EPERC was designed as to be a clearinghouse for educational materials relating to end-of-life care. These are some, actually, pass out some brochures. Includes materials, an educator's bookshelf, and educational opportunities, and a bulletin board. The idea was that Dr. Pereira would develop an educational material of some type. He would send it to us, and then we would send it out for external peer review. And we send it to two people. We send it to a content reviewer and an education reviewer. We get the reviews back, just much like a journal review. We synthesize those into an abstract, and then we post the abstract, which is searchable by topic area or educational methodology. And by the way, since I'm with a group of educators, a couple of you I already have on our list of content and education reviewers. If anyone else is interested in doing this, give me your name. We're always looking for people who want to review materials. We do not post bad reviews. People are always worried about that. If the reviews come back really bad, they'll come back with suggestions for changes to the author. We'll send them back to the author, and they have an opportunity to make changes. But we would never post a review saying, "This is garbage. This should never be used." We wouldn't do that. We're nice people. The educational materials that we're looking for are course curriculum, topic-specific teaching modules, web-based education, self-study guides, computer programs, AV tapes, and any types of evaluation tools. The bookshelf is probably one of our most popular sites. It has lists of references in each content area. We keep a list of calls for abstracts and meetings, links, and a listing of educational opportunities. Those of you who run fellowship programs, if you want us to post an announcement, we'll put it on our website. No charge. You can email me the information, and we will post it on the EPERC site, or you can send it in yourself by accessing the site. Any of the courses you've described that you'd like to get more, dissemination about, just send it to us and we'll post it on the site. This is just one of the pages, a search page, and you can search for all kinds of different things in different ways. Current topic areas, they're all the ones you'd expect. We do cover the whole breadth of advanced illness and palliative care. We do have a What's New page that goes out, and we have, if you register, you'll get every week a listserv message about what's new on EPERC, what's anything that's we think is we want to bring your attention to. Fast facts and concepts. This was I run this residency education project around the country, and one of the residency programs developed this thing that they called Fast Facts and Concepts. Was the coordinator for the project wrote up a one-page little bullet thing about key teaching points on a particular topic. So what are the 8 things that every attending physician should know about advance directives? And then he stuffed it in everybody's mailbox, and all the faculty mailboxes. And he said the response was incredible. Faculty who would never talk to him about dying before or dying patients came up to him and wanted to talk about it. And the response was so positive, we decided to take this into EPERC and into a email system, so that we now, every 2 weeks, we develop a new fast fact that we distribute into the EPERC site. We distribute it also through an email site that are basically one-page reference summary of key teaching information. It's designed for teaching faculty, but this is also, there's probably hundreds of nurses on our email list who want these for their nursing staff, social workers who get them. They're suitable for rounds discussion. People do stuff them in mailboxes, they email them on. The goal of these is to disseminate them as much as possible. I have to say, of all the teaching I've done in the last 15 years, nothing has had as much impact as this. A one-page set of very simple things. And I think the issue is that we send this out to people. We don't ask them. We just send it to them. And it gets back to the issue of they don't have to feel stupid about asking about material they don't know. So we're sending them something, and they read it, and we do get responses back are just phenomenal. You know, I've never thought of this before. This is terrific. And interestingly, of all the fast facts we've done, we've got about 40 out now. The one that's been most popular was how to write a condolence letter. I got emails back from faculty saying, you know, I've never known what to say. This is really helpful. Thank you. So people use it for themselves. They pass it on to their residents. It's really just a terrific tool. This is our current stats from EPERC. 2,100 users, 46 countries, 20,000 page hits a month, blah, 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 blah. Our newest thing that we're going to be starting this summer is called Edumentals, which is taken off the EPERC. And instead of a end-of-life content, it's going to be a one-page reference, a summary of teaching information. So, how do you write a case study? How do you write a test question? How do you develop a learner assessment form for whoever? How do you teach in the clinic? And this is going to be solely, this is going to be really focused on education, and there'll be case examples that'll be based on palliative care teaching. Thanks very much. Thank you.